Okay, so my clock now shows 10:03, and so I guess we can start the webinar now. Assalamualaikum and a very good morning to all of you, participants and also role players. My name is Muhammad Sinatra. I'm an analyst at ISIS Malaysia, and I would like to personally welcome you all to this Foreign Policy Speaker Series webinar entitled New Strategies for the Pandemic Second Year. It's very heartwarming to see around 60 participants joining us for today's program, and we hope to see more as we progress this morning. So just a quick introduction to this Foreign Policy Speaker Series. For those of you who are unfamiliar with the format, this webinar is part of a larger Foreign Policy Speaker Series established through a collaboration between ISIS Malaysia and the US Embassy in Kuala Lumpur. The series began on 10th February 2021, so we are very young, and aims to cover a wide array of themes, including global foreign policy, the environment, human rights, South China Sea, economics and trade, women's empowerment, public health, as well as cyber security. And today's webinar is the third in this series, I believe, and each webinar comprises speakers from both Malaysia and the United States who bring their expertise to bear on their topics, as well as discuss the implications for Malaysia, the United States, and the Malaysia and US relations. So before we begin today's processions, I would personally invite Mr. Sean Brennan, Economic Officer at the US Embassy in Kuala Lumpur, to deliver his welcome remarks.
Good morning, thank you. My name is Sean Brennan. I am the Economic Officer with the Health Portfolio here at the US Embassy in Kuala Lumpur. I'm delighted to be here and to be part of this next edition of our virtual Foreign Policy Speaker Series in collaboration with ISIS Malaysia. On behalf of the US Embassy, I would like to thank our expert speakers for joining us today. This morning, we have Dr. John MacArthur, the Regional Director of the Southeast Asia Office of the US Centers for Disease Control and Prevention, which you may commonly know as the CDC. We also have, Dr. Sui Kung Kaur, currently a visiting fellow at ISIS Malaysia and a noted Malaysian expert on the issues at hand today. You may already be familiar with Dr. Kaur's published pieces in the South China Morning Post and The Star, among others. It is my pleasure to welcome you both this morning. Thank you for being here. It has been just over 2 months since the Biden administration took office. In that short time, a great deal has happened on the global health front, not least of which, of course, is the arrival of the first COVID-19 vaccines here in Malaysia. With vaccines arriving on the ground in countries all over the world, production delays, issues of inclusion and of economic recovery are trending and on the front page of every newspaper. The United States has committed to prioritizing global health in order to save lives, promote economic recovery, and build better resilience against future biological catastrophes. To achieve this, President Biden announced on February 19 that the United States is giving an initial $2 billion to the COVAX facility to vaccinate people all around the world. We will provide another $2 billion at a later time, and we want to work with other nations when that happens, such as Malaysia, a fellow COVAX participant, to expand support for COVAX and scale up vaccine manufacturing, supplies, and distribution. In addition to this, the United States made a historic pledge in 2020 to provide $1.6 billion to immunize 300 million more children around the world against vaccine-preventable diseases. We are committed to addressing the secondary and tertiary impacts of this pandemic with an additional $1.6 billion for our foreign affairs agencies to prevent, prepare for, and respond to future pandemic diseases. This builds on our years of contributions to building the capacity of local healthcare systems. Since 2001, the United States government has given more than $140 billion for this purpose. However, one country's contributions alone will not contain this pandemic. It requires a global solution and commitments from governments across the world. The US, Malaysia, and the entire globe are in this fight together. So thank you all for being part of this event today, and I look forward to listening to the fruitful discussion. Thank you.
Thank you very much, Mr. Brendan, for that very substantial welcome remarks. And again, I would like to take this opportunity to extend ISIS Malaysia's deep gratitude to the US Embassy in Kuala Lumpur for its valuable and enduring support to make us our mission in bringing strategic and robust conversations such as this to the public. So thank you very much, the US Embassy in Kuala Lumpur. Again, I would like to welcome all of you who just joined us this morning. This is a Foreign Policy Speaker Series webinar on new strategies for the pandemic second year. To conserve on time, I will not read the session description again because I'm pretty sure you've read it from our posters or flyers. But let me just take this moment to say a few words regarding the topic itself. So the subject of the pandemic and COVID-19 public health are probably some of the most oversaturated subjects in our public mind at the moment. But we at ISIS Malaysia believe there is a need to understand that the narratives, challenges, and as well as concerns in the second year of the pandemic differ greatly from last year. The year 2020, for example, introduced us to some concepts such as lockdown, social distancing, swab tests, and masks. Many of these were alien to the most of us back then. But in 2021, we were suddenly exposed to all these new challenges such as vaccine nationalism, vaccine supply or lack of supply, global inequality, resource hoarding, as well as infodemic. So the international politics lie at the bottom of these challenges because whether or not the countries worldwide are willing to cooperate in sharing resources would determine whether the world will be successful in handling the pandemic or not. And as Mr. Brennan said, the United States' recent initiatives to re-engage WHO and contribute to COVAX has actually provided good examples of how multilateralism works. And it has also given us in Malaysia some incentives to explore ways to cooperate with the United States on public health matters. And I believe it's the ultimate mission of this webinar to identify some of these trends and challenges and bring it to you, our audience, in the most in critical but also presentable ways. So I'm already joined by a panel of experts this morning. Joining me, our first speaker is Dr. John MacArthur. He's Regional Director of the Center for Disease and Control and Prevention Southeast Asia Office in Hanoi, Vietnam. And I believe this is Dr. John MacArthur's first engagement with us at ISIS Malaysia. So I would like to extend a very warm welcome to you, Dr. MacArthur. Our second speaker is Dr. Kaur, Dr. Kaur Swikan Kaur, an ISIS Malaysia regular. He is also ISIS Malaysia's visiting fellow and an associate fellow at the Chatham House, the United Kingdom. Last but not least is Ms. Ainun Jabi, my amazing colleague, who will join me in navigating the Q&A section later. She is a senior researcher at ISIS Malaysia's Technology, Innovation, Environment, and Sustainability Division, or TICE. And she's also our in-house expert for anything related to the environment and sustainability. So a brief introduction to the format of this webinar. Each speaker will be given an initial 8 to 10 minutes to deliver their initial remarks. Following the end of the presentation segments, we would initiate the Q&A section, which will be handled by Ainun. And that would last for about 30 to 45 minutes, depending on the time that we have. Participants are invited to use the Q&A window in the Zoom software to ask their questions. Please make sure that you are using this function and not the chat function so as to enable us to navigate the conversation better. But if you prefer to deliver your questions verbally, you may use the raise hand function to identify yourselves. Then we'll identify you and allow the mic to for you to deliver your questions. But for everyone, please please keep in mind that your question must be brief and concise so as to enable as many views and questions as possible. So without further ado, I would first invite Dr. John MacArthur to deliver his presentation. Over to you, Dr. MacArthur.
Thank you so much, Mr. Hamid. What I'm going to do in terms of assisting with couching my initial remarks is to give a short PowerPoint presentation, just going over some of the historical context of emerging infectious diseases in the Southeast Asia region, what countries in the region have done to prepare themselves, and then say a few things about how CDC is providing some assistance with that. So I am going to go ahead and share a screen right now. Perhaps just to start, to make sure that that is visible to the participants.
Yeah, we can see your slides.
Okay, excellent. Thank you so much. Sorry, I'm just, there we go. So what I want to do is, again, is just to briefly go over, I think, some major events that have happened in Southeast Asia over the last 20 years, and essentially why I often tell people around the world why Asia matters with regards to emerging infectious diseases. So as many of you know, Asia is a very dynamic region. There's tremendous economic growth. And with that economic growth, we're seeing people moving from rural areas into urban areas, and there's vast urbanization occurring throughout the region. This economic growth is also driving environmental changes. One of the things we're finding is that as humans start to congregate together, they need to be fed. And maybe a generation, 2 generations ago, those families would raise their protein sources on their farms. But now, as they move into large urban centers, they need to be close to those protein sources because they're no longer farming. So what we see is mobility of people into these urban areas, but also mobility of animals into those urban areas. And those animals often provide a very fertile condition for the transmission of diseases from animals to humans. We also see a very diverse zoonotic and vector-borne pathogens, so diseases that are either transmitted from animals to humans or transmitted from insects to humans throughout the region. And then we see ecologic factors that we don't fully understand that have led to rapid mutation of these pathogens. So this map just gives you an idea of some hotspots of emerging diseases that originate in wildlife throughout the world. Just to orientate you, red areas are high risk, yellow moderate risk, and green is low risk. And so if I may just draw your attention to the Asia region, you'll see that the vast majority of the region where we live is considered high risk for diseases to be transmitted from wild animals to humans. Here is an example of a number of pictures that were taken in markets throughout the region. You'll see poultry in these markets. You'll see pigs in these markets. You will see fish in these markets. You'll also see wildlife or game that's been brought in for sale. So I just want to walk us through really the last 20 years of, as I mentioned earlier in my opening comments, of some what I think are seminal events with regards to emerging infectious diseases. If we go back to the late 90s, we saw Nipah virus actually originate in Malaysia that infected 300 persons and killed 100. So 1 in 3 people died of this. Through investigations, we learned that that virus was most likely transmitted to humans from infected bats. And those bats either directly transmitted the virus to the humans or through urine or through eating fruit and dropping it into areas where pigs were. Those pigs became infected and transmitted to humans. I will note that this is an early example of the collaboration that CDC has had with Asian countries. The academics who were investigating this in Malaysia were unable to diagnose the disease because they hadn't seen it before, and they reached out to CDC headquarters in Atlanta, and the laboratory provided assistance. They were able to then isolate this new virus. We move forward to SARS, which was first identified in 2003. Ultimately, this was really the first coronavirus that had significant impact on human health. We ultimately saw over 8,000 human cases, leading to almost 775 deaths. Again, we believe that the origin of this was in wild animals and transmitted to humans. And then if we move forward into, say, the mid-2000s, we saw first avian flu, or avian influenza, bird flu, and then pandemic influenza, H1N1. So the avian influenza, known as H5N1, was first reported in humans in the late 90s in Hong Kong, ultimately infected almost 850 people, leading to almost 450 deaths through mid-2015. Again, the origin of this was these persons had direct or close contact with infected poultry. With H1N1, which was, believe it or not, a pandemic a decade ago or more, was first reported in the United States and led to over 61 million cases around the world and more than 12,000 deaths. Now, this virus was thought to be a reassortment or a mixing of a bird virus, a pig virus, and a human virus that came together and essentially created a virus that was much more transmissible, hence moving around the world quite quickly. So out here in Asia, I'd like to say that we have, when we look at emerging and re-emerging infectious diseases, we have everything from A to Z. So from artemisinin-resistant malaria all the way to Zika. The other thing that we have as a part of that dynamic economic environment is quite a lot of migration. Now, this map shows some migratory patterns, mostly in the greater Mekong subregion, but it dips down a little bit to Malaysia as well. And you can see how people throughout the region are migrating, often looking for employment possibilities. Here are a few snapshots that I took on the Thai-Myanmar border. And the one picture on the left is a formal border crossing at what they call the Friendship Bridge. So this is in Mae Sot, Tak province of Thailand, and across that bridge is Myawaddy in Kayah State in Myanmar. So that's the formal border crossing. Now the picture on the right, if you went with me to this formal border crossing and we just walked, say, 500 meters south of this formal border crossings, you'll see this informal border crossing, which for 20 baht, Thai baht, which is about 60 US cents, these persons can pay the boatman who will take them across the river into Thailand quite easily. Another picture of that is the Thai-Malaysia border. So again, the picture on the left is the formal border crossing between Thailand and Malaysia. And then the picture on the right is a boat that's carrying migrants from Myanmar into Malaysia. So we also have expanded travel, not just informally or formally across borders, but air traffic. So 1 or 2 generations ago, people tended to stay in their homes and didn't travel very far. But of course, now you can get on one of these super airplanes and get from point A to point B halfway around the world in as little as 24 hours. So this map gives an idea of how easy it is to travel around the world. This is a global aviation network map, and any given day, pre-COVID, you'll see where flights are going. I want to just again draw your attention to the region in which we live, Southeast Asia, and you'll see that 3 major points of travel are North America, Western Europe, and Southeast Asia, which means that diseases that originate in North America, originate in Europe, originate in Southeast Asia can easily get on an airplane and travel. It's often said that infectious diseases know no borders. Therefore, a health threat anywhere in the world is a health threat everywhere because of the ease in which people travel. So I want to transition now and talk a little bit about some global frameworks that have helped strengthen health security, mostly in Southeast Asia, but other parts of the world as well. So we'll start with the international health regulations. And these really came out of an afterwash after the SARS epidemic, where WHO and member states looked at the preparedness of countries and realized that really the countries were not necessarily prepared to meet major public health threats such as SARS. So in 2005, 196 member states of the World Health Organization came together and signed on to the international health regulations of the IHR. Essentially, this served as a framework for countries to identify and to report, as well as respond to public health emergencies of international concern. So these are major public health emergencies that can cross borders and cause problems in other countries. In order to implement the IHRs, the Asia Pacific region came together through both regional offices of the World Health Organization, the Southeast Asia Regional Office and the Western Pacific Regional Office, and developed a strategy for emerging diseases in which they could then say, these are concrete examples of steps that we can take to better prepare ourselves for any type of public health threat. There are 5 main strategies in this Asia Pacific strategy for emerging diseases. First one is to reduce the risk of emerging diseases, to strengthen countries' ability for early detection, to strengthen countries' ability to respond rapidly when they do detect a pathogen of concern, to build and strengthen effective preparedness systems in the country so that the countries are prepared for the introduction of these emerging infectious diseases, and then to work on partnerships both within the country and around the region.
Sorry, Dr. MacArthur, can you wrap up in 1 minute?
Yes, of course. And then within the Global Health Security Agenda is another framework in which we are working to prevent, to detect, and to respond to public health threats. So CDC has been working hand in glove with countries throughout this region to really prepare for these emerging infectious diseases. Since SARS and H5N1 or bird flu, we've increased assistance to the region to prepare for pandemics and other emerging infectious diseases through key areas of health system strengthening. We've worked with WHO and other partners on these frameworks that I've already mentioned. Now, COVID-19 is a significant event, clearly around the world and clearly in Asia. But I would argue that Asia is doing relatively well in comparison to the global community. And here is just an example of this. These are data that I took just a few days ago. I just want to highlight the column, which is cases per 100,000. You'll see that when adjusted for population, the member states within ASEAN have really a third or better the number of cases per population to the global situation with regards to COVID. So Mr. Mohammed, that concludes my comments, and I'll turn the presentation back to you.
Thank you very much, Dr. MacArthur. Thank you for introducing us to these close linkages between economic development and also like vulnerabilities to infectious diseases. Especially, it was especially mind-blowing to me the fact that Asia remains vulnerable to emerging diseases in the future. And I would also like to thank you for introducing some of these global frameworks that are available today in helping us to battle the COVID-19 pandemic at the moment. I will now invite Dr. Ko to deliver his remarks.
Thank you, Sinatra, and everyone. Can I just do a tech check first that you can see me, hear me, and see my screen?
Yeah, I can hear you. I can see your fantastic presentation.
Well, thank you, Sinatra. Haven't started yet. So thank you, Dr. MacArthur, or John, if I may, for your great set of remarks that sketch out the importance of Asia and the importance of Southeast Asia. You've also given us a framework for how we can understand global health governance, especially as it relates to foreign policy. And I'll build on some of the things that you said by focusing on how we can strengthen the international health regulations. Ladies and gentlemen, we're here speaking today about new strategies for the pandemic's second year. We've had 1 year of COVID. Let's see what is likely to happen and how we can respond to the second year of this pandemic. It's likely to be the second of many years of this pandemic. This will not be the last year of the pandemic, even with the vaccines coming up. So as I continue, a brief set of thanks to ISIS Malaysia, as well as to the US Embassy in Kuala Lumpur. I begin with a short disclosure that I have no conflicts of interest and the opinions expressed here are my own. Currently, I have fellowships in 3 places, including in ISIS Malaysia. Previously, I worked in medicine, in refugee work, in clinical research and pharma anti-corruption as well, with some training in medicine, public health and public policy. Ladies and gentlemen, these are my disclosures and my intro. I really have just this one slide, in this one slide, and I hope to talk about it for the next, say, 8 minutes or so, 8 to 9 minutes. And in this one slide, I would like to share 3 pandemic strategies for the second year of this pandemic. For the second year of COVID, there are 3 things that we should do. Firstly, to strengthen health systems in blue, and I'll elaborate in that box in blue. The first priority is to strengthen health systems. The second priority in the second year of this pandemic is to achieve vaccine equity, whatever that means. And I will give 3 specific ways of how we can quickly achieve vaccine equity in the second year of the pandemic. And that's in the center of the screen in orange. In blue, the third strategy for this year, the second year of this pandemic, is for us to strengthen global health governance. And this builds on a lot of what John has mentioned earlier, especially about the international health regulations. Ladies and gentlemen, let's move on to the first strategy. In this multi-year pandemic, we must be recognizing the fact that our health systems must be strengthened in the second year and onwards as well. And I think that we can strengthen this in 3 different levels. Firstly, at the country level, secondly, at the regional Southeast Asia level, and thirdly, at the global level as well. We'll take these 3 in turn in the box in blue on the left of the screen. We'll see at the country level, one of the first priorities for us in the second year of this pandemic is to provide a period of rest for the health system itself and also the health workers inside the health system. What I mean to say is, after a year of fighting the pandemic, they need rest. And this is not just physical, but mental, emotional, psychological, and also systemic. At the same time, countries must also remember to reform and strengthen their health system, specifically in sustainable financing. We have seen that the COVID pandemic is not just a health problem, it is an economic problem, political problem, social problem, etc. But all that interplays with the health system or hospitals and doctors and clinics and nurses ultimately being the backstop or the final solution, or the last line of defense for any country. Therefore, you need to continually strengthen the health system, specifically in providing enough financing for it to continue. Thirdly, at the country level, in Southeast Asia, in Vietnam, Indonesia, Malaysia, and so on, is to integrate the vaccination program objectives with overall public health objectives. What I mean to say is we cannot let the vaccination program run on its own and have its own objectives and overshadow things like contact tracing, movement tracking, and appropriate, say, isolation, quarantine policies, and whatever lockdown policies are in place in the various countries in Southeast Asia. So what I mean to say is public health is much higher, vaccination serves public health objectives and not the other way around. Ladies and gentlemen, at the regional Southeast Asia level as well, we must consider a few things. Firstly, whether or not we should have a standalone ASEAN CDC or whatever we call it. I'm not wedded to the name CDC. We already have a Humanitarian Assistance and Coordination Center, the AHA Center, that's coordinated by the ASEAN Secretariat, or is a part of the ASEAN framework. But we perhaps need to be a bit more ambitious, and that's a multi-year program for us to get an ASEAN CDC, and we need to start that work today. The second thing we need to do in the Southeast Asia region is to implement as quickly as possible the ACRF, or the ASEAN Comprehensive Recovery Framework. And this is in terms of foreign policy as well. It was approved in November 2020 during the ASEAN Summit in Vietnam. It contains a very significant health input, which I think is important. What I mean to say is if you implement the ACRF, not only in health terms, but also in the political, economic, and social terms, it would strengthen health systems and enable us to eliminate or even eradicate this pandemic in the years to come. Thirdly, and finally, in the regional Southeast Asia element is to have more ASEAN collaboration. For example, pooled vaccine procurement, like what they do in the Pan American Health Organization, PAHO with their revolving fund, or maybe even to consider equipment stockpiles. Some of this is already done by the AHA Center, but we could definitely accelerate that a little bit more. In terms of strengthening health systems at the global level, now I'm going to give 3 themes over here because global health systems aren't easy to reform because a lot of health systems operate still at the country level. So the three themes at the global level for the second year of this pandemic that will definitely influence foreign policy would be, firstly, primary health, to strengthen primary health and also community health workers, to develop new models of public-private partnerships in terms of healthcare, and finally, to mention something that Sinatra brought up earlier, our moderator brought up earlier, to fight the infodemic and fake news in a post-truth era. Because a lot of this is, for example, spread on Facebook, and Facebook is a multinational, supranational platform that we cannot govern very easily from Malaysia or Jakarta, and we must really go to San Francisco for us to be able to effectively engage with Facebook. This is how we can strengthen health systems in the second year of this pandemic. Let me move on to something very specific in terms of the second year of this pandemic, in terms of achieving vaccine equity. And this has a lot of implications on foreign policy. There are three main ways to achieve vaccine equity. Firstly, we need more vaccines quicker. Secondly, whatever vaccines we have, we need to distribute more fairly. And thirdly, we need clearer global leadership. So for example, in terms of producing more vaccines quickly, we need to consider, as in the whole world needs to consider, more technology transfers, like AstraZeneca to Siam Biosciences in Thailand, or more in-licensing. For example, Merck Sharp and Dohme, MSD, is making J&J vaccines. So the spare manufacturing capacity for any number of vaccine manufacturers in this world can actually be redeployed. So when we see that MSD is making J&J vaccines, it opens up all sorts of possibilities for us to produce more vaccines quickly. The second way to produce more vaccines quickly is to leverage on Indian pharmaceutical manufacturers. And Indian pharmaceutical manufacturers, for example, at the Serum Institute of India, makes 40% of the world's vaccines for diphtheria, pertussis, tetanus, hepatitis B, etc. And that capacity can really be deployed very quickly. Now, this has foreign policy implications as well. Producing more vaccines is the first strategy, but then we need to distribute more fairly. For example, we need to repeal export control laws, like Europe's export control laws that prevent them from exporting AstraZeneca vaccines, even to their allies like Australia, needs to be repealed. We need to provide more funds to COVAX. So what Sean has mentioned earlier, that the Biden administration has committed $4 billion to COVAX, that helps them meet the funding gap. So there's still, unfortunately, a gap of about 25 billion in COVAX. And that is a foreign policy decision to give more funds to COVAX. Thirdly, there needs to be clear rules for vaccine donations. Canada, for example, has purchased vaccines up to 9 times their population. At some point, these vaccines will expire. And if Canada wants to, or must even, donate these vaccines out to the rest of the world, we need rules, clear ones for vaccine donations to ensure, for example, a minimum period before the expiry, that I don't give you a vaccine that's 1 week before expiry, but I give it to you 3 months or 6 months before expiry. And this is how we can distribute the vaccines more fairly. Thirdly, and finally, to achieve vaccine equity, we obviously need clearer global leadership. What I mean to say is the Chinese government, the United Nations, and the US leadership will be very crucial in helping us achieve vaccine equity. And this is a problem of distribution of global public goods. It's a collective action problem. When nobody acts because everybody's acting in their own self-interest, then we need a strong leadership in order to come in to break the impasse. So I'll then move on by saying that the United Nations General Assembly and the United Nations Security Council has been very quiet in the first year of this pandemic. In the first year of this pandemic, there's only been one Security Council resolution that has been issued on COVID-19 in 2020. And every other Security Council resolution has been about conflict and violence. If the Security Council is truly a security council, then global health security will need to be in it as well. I understand that the permanent 5 members of the United Nations Security Council and the Security Council framework is itself very problematic because it's very colonial and post-Second World War, but perhaps this is the strongest or highest body of decision-making around the world. Thirdly and finally, in terms of clearer global leadership, we need the multilateral finance agencies to be more engaged. So we've got the pandemic bonds of the World Bank, which is great. We've got the Asian Development Bank coming up with a $9 billion funding facility for COVID vaccines, and that's great. We've got the Asian Infrastructure Investment Bank coming up with an infrastructure for the Health Silk Road, and that's great as well, but we need them to be more engaged in a very consistent manner. Ladies and gentlemen, I've given you the strengthening health systems as the first strategy, achieving vaccine equity as the second strategy. I'll then spend the next 4 minutes or 3 minutes or so talking about strengthening global health governance. And this builds on what John has said earlier in his remarks. In the box in blue, sketches are my elaborations. Firstly, is to strengthen the international health regulations, but there's a problem. There's a problem because global health governance, or GH governance, as I've listed over here, has similar challenges to governance of other global public goods, like nuclear weapons, like climate change, like fisheries, like digital taxes, like what have you. These global challenges perhaps cannot be resolved with existing infrastructure. We may need to strengthen existing infrastructure or perhaps build new ones. So to elaborate a little bit more on the international health regulations, it is unfortunately not binding enough. Joint external evaluations, or JEEs, are used to monitor whether or not countries are following international health regulations. In a sense, they're like auditing. We're having the World Health Organization act as an auditing partner for country-level organizations or countries' ministries of health. And WHO should really consider sanctions as a tool to encourage adherence. I know I'm proposing something quite dramatic over here, but we're in the middle of a global pandemic. This is an opportunity for us to think of solutions that we've never really thought of before. And if the WHO cannot introduce sanctions as a part of the JEE process, then maybe the General Assembly and the Security Council needs to come in. But there are other models for compliance. In terms of foreign policy, this crosses all sorts of barriers. For example, not just health, but also talking about security policy, political policy, international relations, economics, geopolitics, geoeconomics, etc. In climate change, we can learn from the Paris Agreement's nationally determined contributions. What nationally determined contributions are is that country A can only emit X number of tons of carbon dioxide in any given year, and country B can only emit Y number of tons of carbon dioxide in any given year.
Sorry,
yes,
Dr. Go, can you wrap up quickly?
Sure, I can. And not only in climate change, but there are also examples in treaties like the FCTC, adding health to the ESG criteria for BlackRock, which has 7.7 trillion US dollars in assets, maybe instituting a minimum spending for health, like NATO's or the North Atlantic Treaty Organization's 2% of GDP on defense. There could be an 8% of GDP on health. We're here talking a little bit with a US flavor, so maybe in the Q&A we can talk about this as well. The role of the United States is fourfold: to deliver political, financial, technical, as well as moral leadership when it comes to the pandemic in this year and also beyond. Sinatra, sorry for taking extra time. Over to you.
No worries at all, Dr. Ko. And thank you very much for your very concise and brief presentations. You, as expected, you raised some of the strategic concerns that we should look at today. So we are now heading to our Q&A segment. I will pass over the floor to Ms. Ainun Jabi, my colleague at ISIS Malaysia, to navigate this session. And please, our audience, if you have any questions, please don't be intimidated by us. Please drop your questions at the Q&A functions or raise your hand if you'd like.
Right. Cool. Thanks, Sinatra. Thanks, Dr. John MacArthur and Dr. Ko. Before I begin this Q&A session, just again, gentle reminder to encourage everyone to use the Q&A function so that we can have a more fruitful discussion. Before I open the floor, maybe for the first round of discussion, I would like to share, to share one question to Dr. John MacArthur. Mainly want to seek for your opinion, about suspension of vaccination program in other countries, and how this situation might affect the momentum of vaccination program in Southeast Asia. That's for Dr. John MacArthur. And for Dr. Ko, for this first round, Dr. Ko, just wondering about your views on vaccine pattern as an opportunity to the less fortunate countries. So just wondering what's your view on that. And after that, we can proceed with the Q&A. I mean, maybe we can proceed with the Q&A section from the floor. But before that, Dr. John, maybe you can enlighten us. Thank you.
Well, thank you so much. Your microphone is not very strong, but I think the question was related to how Southeast Asia can learn from other parts of the world's experience in vaccination as they're ramping up their vaccination. I think one of the things that we realize, and I highlighted this a little bit with my talk, the interconnectedness of the global community around this pandemic. And I think not only are we interconnected because the pathogen is traveling from country to country and infecting other people, but we're interconnected from experiences. So I'll give you an example of that. Southeast Asia was an early adopter of universal mask wearing, and so many of the countries here, perhaps because of some of their experiences with the diseases that I mentioned in my presentation, quickly adopted mask usage, while the World Health Organization and my own agency, CDC, were basically saying, well, the data don't suggest that we should use the mask. And both WHO and CDC were suggesting that mask usage only be limited to healthcare workers and not the general public, unless the general public was ill. Well, I think that CDC and WHO learned from Asia, and we realized that you had a lot of experience in these respiratory diseases, and we quickly learned that, in fact, those who wore masks were less likely to become infected and less likely to infect. And so we, meaning the United States, and clearly WHO, learned from Southeast Asia with regards to mask usage. With regards to vaccination, I think, again, there's a lot of information being shared around the world, as certain countries are maybe a few steps ahead of Southeast Asia in their implementation of the vaccination process. They're sharing those experiences with Southeast Asia, so that countries here can learn what worked and what didn't work, in terms of who you target, when you target it, when you open it up for all ages, how do you do mass vaccination versus how do you use the public sector, how you use the private sector. So one of the things that CDC has within our emergency response is a unit that is dedicated to providing technical assistance to not only countries in Southeast Asia, but countries around the world to try to help them to implement an effective vaccination strategy. Because I would say that vaccines don't save lives. Vaccination saves lives. So we need to get those vaccines into the people that are necessary. Back over to you, Madam Chair.
Wonderful. Thanks, Dr. McCarthy. Yeah, Dr. Cole?
Thank you. Can I confirm that you asked me about vaccine patents, as in the intellectual property for vaccines? Got it. Okay. So I will answer in two parts. The first part is to sketch out a little bit of the problem statement, and then secondly, hopefully to provide a partial solution to the problem, because it's a really big one. One of the problems of not getting enough vaccines quickly is that companies are holding on to their patents. This is not new, because in the pharmaceutical industry, patents are used as a way to incentivize innovation. But if taken to its extreme, patents could be destructive in the sense that you are not allowing full access to the medicines, you're charging too higher price for the medicines, and people will not be able to benefit. What do I think about the patent system? Two things. One, in the short term, there is a strong moral, economic, political, foreign policy, and public health case to share these patents out. Even without royalties, a company like Pfizer will be able to benefit tremendously from selling their, say, in a tiered pricing environment, selling the vaccine to those who can pay, but licensing it out to countries that cannot pay. And tiered pricing is a concept that is used in the pharmaceutical industry that is quite widely accepted as a reasonable way to ensure the balance between innovation and at the same time ensuring access to the large swathes of the population, or very large numbers of people. So in the short term, there is a strong case to be made to share these patents. And the WHO already has a mechanism for you to share these patents with them. Unfortunately, this mechanism is not well supported by various pharmaceutical companies. I think one important note is AstraZeneca that has said that they'll be very happy to distribute the patent and to allow large doses of their vaccine to be manufactured and then sold and distributed without royalty, given this is a global health crisis. This is in the short term. In the long term, we probably need reforms of the global patent system and global intellectual property system. And this is, I think, beyond a short answer, beyond me just saying reforms are needed. Very many people are specializing in this field. Maybe ISIS would like to convene a separate conversation about how we can actually reform the intellectual property system of the world to ensure a balance between innovation as well as access to medicines. Thank you. Ainon, over to you.
Yep, thanks, Dr. Kaur. Thanks also for the proposal for us to discuss more on these IP issues. So moving on to the Q&A section, so a bit specific. I think the first question here was asking about vaccine passport issue. So how can we ensure that there will be no discrimination against those who cannot be vaccinated when we open borders later, since most countries have not standardized relevant policy? Maybe Dr. John MacArthur can quickly respond on this regarding vaccine passport. Dr. John, over to you.
Sure. I think there's certainly a lot of discussion and dialogue right now by a variety of interested parties on how to develop and how to implement a vaccine passport program. I don't think that there's consensus right now. I think within Southeast Asia, clearly this is a topic of conversation because many, if not most, of the Southeast Asian countries have essentially closed their borders to international travel. Or if the travelers come in, they usually are a select few and then are subjected to a 2-week quarantine. Well, that's perfectly fine if you're a diplomat like myself coming in, or you're returning citizen coming in. But for countries in Southeast Asia that rely on tourism or rely on international business, it's really having a significant impact on their economies. And so I know that, there's quite a discussion with that. I think one of the things that needs to occur is we still need to learn more about this vaccine. So, there's still unknowns in terms of how long is it going to be effective. People who are vaccinated, can they transmit the virus to others? These are still some unknown questions that the scientists are still looking for the answers to. And my sense is that it's all about risk management, right? And so at what point do you allow somebody coming in who've been vaccinated without a quarantine, and at what point are the policy makers in a country feeling comfortable? But with regards to the sort of how can you distribute vaccine passport in an equitable way, I think that's linked to the question of how can you distribute vaccines in an equitable way. And obviously our goal globally is to get the vaccines to all people around the world as quickly as possible, regardless of their social status or their job characteristic or their age or the risk factors.
Yep. Thanks, Dr. MacArthur. Noted point taken, especially risk management is key in this to approach this issue. Right. Moving on to the next question, specifically for Dr. Kaur, a little bit case specific on health worker here. Let me read the sentence. So our participants want to know how can we raise our health system and health workers when they not only have to look after COVID cases first and detect COVID cases as well, they all need to be taken care of other health associated manners. So in relation to the health workers, yeah, your comment on that. Thank you.
Thank you, Ainon, and thank you, Dr. Nuraza. It's lovely to hear from you. If I can combine Noraza's question with Zulfatli's question, which is roughly the same, and the audience can read it in the Q&A as well. So I'm going to combine the answers in perhaps and make two comments. The first one is we acknowledge that there is a lot of work and burdens on healthcare workers around the world. Doctors, nurses, paramedics, and pharmacists are all overworked because they're doing, firstly, routine non-COVID work like childbirth, cancer care, diabetes, and so on. On top of that, we're asking them to do a lot of COVID work, not only treating COVID patients, but involved in public health measures, testing, tracing, and so on. Now we're asking them to do vaccinations. In effect, we're asking healthcare workers to do a lot of things, and we're only paying them for one job, which is deliver routine healthcare. On top of that, routine COVID care. On top of that, deliver vaccinations. I admit and agree to all that. I acknowledge and agree to all that, which makes it more important for us to provide scheduled periods of rest for them. And there are three specific things that we can do. The first one is administrative, as in we create an administrative framework where rest is dated. That after every, for example, I'm just inventing over here, this depends on country to country, of course, and operational unit to operational unit, meaning hospital to hospital, should have different policies. Let me sketch out an example. For every 2 weeks of non-stop work, you must take 1 day off. This is written into the law, and that allows the healthcare worker to have a period of rest. Otherwise, they're not machines, and we will exhaust them, they will burn out, they will leave the service, and it's not sustainable. So that's administrative, a scheduled rest period. The second one is to consider that we need more healthcare professionals, and there are two ways that we can get more healthcare professionals. One is to get more into the private sector, coming into the public sector. Either you purchase services or some element of a public-private partnership, or you outsource specific services to them in the private sector. This can mobilize large numbers of people as well. The third and final thing that we can consider to give people rest, right, is to expand the number of people who can do the work. So not only getting private sector people or retired professionals or even veterinarians, to deliver vaccinations, and some countries are getting veterinarians to deliver vaccinations, of course, after proper training. The third and final thing of giving rest to people is to task shift. Task shifting is a way that is approved and endorsed and encouraged by the World Health Organization to shift non-important or easy to do tasks from doctors to nurses, and nurses to paramedics, and paramedics to the community, that they can do all these things by themselves. So you're not truly reliant on a healthcare professional, and therefore your pool of people who are considered healthcare professionals actually grows. Of course, there are issues of training, credentialing, making sure that there's a liability framework, but other countries can do that, have done that already, and these are ways that we can provide rest to our healthcare workers. Ainun, over to you.
Wonderful. Thanks, Dr. Kaur. I feel like I'm listening to a blueprint with action plan needs to be taken moving forward. Right. I can see from the attendance list, Miss Alpenfol, sorry if I didn't pronounce it correctly, would like to give her intervention. So, Miss Kaur, are you okay? I mean, are you ready now?
Yes, I am. Yes, I am.
Cool. Over to you.
All right. Thanks, Ms. Ainun, and to the panelists for their comments and discussions. I just have actually one question, which I've already put in, but I'll just ask it since I'm allowed to. One question on vaccine equity. Given that countries like Malaysia, we have a large number of undocumented migrants or sectors of society that are unaccounted for, how can we achieve vaccine equity? Is it realistic? I mean, for countries like Malaysia to have fair distribution, and if so, what are the timelines like? Who are the stakeholders? That's all. Thank you.
Before that, Ms. Kaur, may I know who you like to address this question?
The person who did the presentation on vaccine equity was Dr. Kaur, so the question is directed to Dr. Kaur.
Okay, Malaysia specific, right? Thanks. All right, Mr. Kaur, Dr. Kaur, sorry, over to you.
Thank you, Ainun and Parveen. Thank you for your question. Your question is vaccine equity realistic? The short answer is yes. Does it mean that it's guaranteed? No. What needs to be done to guarantee a series of political steps? The first political step would probably have to be a stated objective of vaccine equity. That is one. Number two, the second political step or political choice that needs to be made for vaccine equity is to create a decision-making framework in order to ensure vaccine equity. At the moment, we're not immediately clear in Malaysia. I mean, we have a say prioritization, who's in category 1, 2, and 3, but we don't know how these decisions were made and how the subcategories might be added in the future. There is still some time for us to change this framework, including the decision makers for this framework, given that I anticipate some delays in not only the Malaysian program and other programs as well. And then thirdly and finally, in terms of how to get to vaccine equities, obviously in the implementation. And many other countries have got problems, not just Malaysia, in terms of double standards in the implementation of the vaccine program. So in this, I think we are say not alone, by saying that other countries, although they say they want vaccine equity, but in reality, I think it's also quite difficult because the rich and the powerful and the well-connected are almost always going to be ahead of us. But this is different. Vaccines are different from academic scholarships or business opportunities or cinema tickets, for example, where the rich, powerful, they can get whatever they want. It doesn't really matter to me. But vaccines matter to me and should matter to us because it's life-saving. Thank you, Parveen. Ainun, over to you.
Right. Thanks, Dr.
Yes, Ainun, could I comment on that question also, because I think it's an important question, and I want to go back to I want to go back to some of my comments in terms of the movement of people, across borders, movement of people on airplanes, the urbanization and close living conditions of people, and the fact that infectious diseases know no borders, nor do they know immigration status. And so I think we have ample examples around the region, and I'll just highlight Singapore and Thailand as two that have done a fantastic job of controlling COVID, only to find that a new nidus of infection occurred in a community of undocumented migrant workers. And then both countries responded quickly to that and were able to bring those outbreaks under control. With regards to status, I will say the outbreak in Thailand, the governor of the province where the outbreak started was out looking at the response, and unfortunately came in contact with the virus himself, spent more than 2 months in the hospital, including being intubated in the intensive care unit, nearly died. And so again, even your political stature, your social stature, the virus knows no boundaries. So I think it's important, again, that the countries look at all humans, regardless of race, regardless of religion, regardless of gender. We can go through the whole list, and regardless of immigration status. I think if you look at the United States right now, as we roll out our mass immunization program, you'll see that they will vaccinate anybody regardless of their immigration status. And the reason for that is because we know that those people live close with those who are in the country legally, either through citizenship or permanent residency or visas or whatever. And I think that that's happening in other countries, such as Thailand, as they move towards their vaccination plans. They plan on vaccinating the undocumented migrants. So I think whether it's Malaysia or other countries in Southeast Asia, when policymakers are looking at development of their vaccination plans, they really need to be blind to immigration status, because if you don't vaccinate that community, it's going to come back and serve as a nidus for a new infection. So thank you, ma'am.
Thanks, Dr. John MacArthur. I'm moving on to the Q&A section because there are a lot of questions here. I will start with from Amina Mahmood, specifically to Dr. Paul. Here, I think you mentioned about the need for insurance instruments like the World Bank Pandemic Emergency Fund, but these haven't worked so well in real time. So there are administrative commission and payouts are minimal and low. So basically, she was asking, how should financial instruments be better structured on this front? Over to you, Dr. Paul.
Thank you, Aino, and hello, Amina, and great question. Thank you. My first caveat is that I'm not a financing expert, nor am I a developmental finance expert as well. Very clearly stating that one. But as I think through this, Amina, maybe there are two specific things that can be done in terms of structuring the financial instruments better. The first one is to adopt a bit of a reinsurance and insurance and reinsurance model. A lot of this financing, say, elements in terms of a payment, like a pandemic bonds of the World Bank, or even the developmental loans that are provided, don't really have an insurance or a reinsurance component to it. Now, that's an entirely separate field, which I'm not very familiar with, but I think there are many principles in insurance and reinsurance models on a very global scale, very systemic scale, that can be transported into the World Bank or the IMF or the ADB. So this is one thought that I might have. The second one is often when we're providing loans to people, so not so much on that is triggering event and loans that are given over to countries, and this often have conditions attached to it. So it's conditional aid that's the issue at hand over here. Often these conditions are things like democratic progress, or a certain amount of it will be devoted to infrastructure, or some accountability, anti-corruption, anti-embezzlement criteria. These are great criteria. We can add health to this criteria by saying that as a condition for a $10 billion multi-year loan that I'm going to give to you at 1% interest or 0% interest, I'd like you to not only devote yourself to anti-corruption, but also to develop your health infrastructure in the following ways. And that could be, well, conditionality has always been on the development aid scene for very many years already. Adding health should not be overly controversial. In fact, might be less controversial than adding democratic criteria, all things being equal. Thank you for your question, Amina, and I know over to you.
Yeah. Thank you, Dr. Koh. Before I proceed with the Q&A question, I can see Mr. Thomas would like to give his intervention. Thomas, over to you.
Hi, thank you, Ainon. You can hear me, right?
Yep, very
great. So this is really for both speakers, and I want to press you guys on this question of vaccine access and inequality. So, despite multiple warnings, even from early on, we still continue to see, in fact, increased inequality in vaccine access and availability. So some countries are now vaccinating those that are thought to be low risk, while many poor and developing countries still can't secure enough vaccines or afford to deploy them for frontliners and for at-risk communities. So really, I have two questions here. The first is that, is a tiered post-pandemic world order, between different countries and different communities inevitable from the start? I mean, was this goal of trying to achieve vaccine inequality too unrealistic to begin with? And the second really is to do with the COVAX initiative. There's been quite a lot written over the last few months on whether COVAX has approached its aim of an equitable vaccine distribution system correctly. So I just wanted your comments on what has COVAX gotten right so far, and also what it could possibly do better. Thank you.
Thanks, Thomas. Either Dr. John MacArthur or Dr. Koh would like to provide the intervention, please.
I'll start and then let Dr. SK come in after me, because he always has some words of wisdom, I think, carefully thought out. I think I just want to say at this point in time, the U.S. government is committed to vaccine equity and fair vaccine distribution. I mean, we, as I think witnessed in Sean's opening comments, I mean, we've already contributed $2 billion to COVAX, have pledged another $2 billion, and that $4 billion really positions us as the largest donor to the COVAX facility, with over 30% of the funds going in there. And part of that is really trying to mobilize and strengthen the role of COVAX, so it's not just something that looks good, but it's not actually working. And other members of the U.S. government are then reaching out to other development partners around the world to try to increase the contributions from other countries. And I think COVAX will be an extremely important role. It's modeled after similar types of vaccine procurement and distribution systems for regular expanded program immunization vaccines. I think the other important movement was just last week when the governments of the United States, India, Japan, and Australia sort of announced partnership with the Indian pharmaceutical company, I'll just say led by women, run by women, to increase vaccine production from that site to 1 billion vaccines by 2022. And so I think that those types of movements are things that we're doing and encouraging others to do to try to, to decrease these barriers that are causing inequities in vaccines around the world. Because as I've been saying all hour, these diseases know no boundaries. They affect all of us around the world. And so any person, any collection of people, any country that's not immunized is going to have some impact on other countries in the region, other countries in the world. So SK, I'll leave it to you to give any other insights that you may have on that question.
John, these are great thoughts, and thank you. I'll only be able to add just a little bit. Also very conscious of time, so I may restrict my comments to 1 or 2 minutes, in the hopes that perhaps we can invite Thomas Albrecht to come and share some thoughts. He leads the UNHCR in Malaysia. So on the topic of vaccine equity, Thomas might be able to share some other thoughts. Sorry, not Thomas Daniel, Thomas Albrecht. So Thomas Daniel, thank you for both your questions. To the first one about a tiered post-pandemic world order, is it inevitable? Maybe Thomas, I'll say 2 things. The first one is to say that even before COVID, we've already had a tiered and very unequal world. And during crises, usually it sharpens that inequality and makes that, shall we say, the separation of powers even greater between the top and the very bottom. So that I might say that pessimistically, it will sharpen inequality. But optimistically, there have been also situations in the past where crises have led to improvements. And I can think of a few examples. The first one is after the Great Depression in the US, when Roosevelt came out with the New Deal. And that was great because it really set the US on a very sound footing, infrastructure and so on. The second example would be the Marshall Plan. After the devastation of the Second World War in Europe, America led the way or supported the reconstruction of Europe. And these are 2 examples of how, maybe the third example of the global financial crisis in 2009, after which we had a series of infrastructure and a stronger financial stability board with global rules for global capital and tier 1 capital in global systemically important banks. The point I'm making is that crises can be used as an opportunity to build back better. We just have to be very conscious about these opportunities. Otherwise, we will go back to worsening inequality. Thomas, your second question is about COVAX, and maybe I'll share just one specific thought about how COVAX can do better. I like COVAX. I think it's great, and it's doing a lot for the world. But there's one challenge because it was built almost from nothing, and we're building COVAX and investing a lot of money in COVAX almost at the expense of the existing United Nations framework. If the world is making a strategic decision that we want to build a new infrastructure for vaccine equity and therapeutics equity, because COVAX is just for vaccines, there are the 3 more pillars, which is vaccines, medicines, diagnostic kits, and fourthly, health system connectors. If we want to build a separate United Nations or WHO framework, then that should be a conscious strategic decision. I don't think we should make that decision though. I think at some point, the COVAX and their sister organizations should really come back into the WHO fold, because the UN system, although imperfect, is probably inevitable and very necessary for this world. Ainun, over to you.
Cool. Thanks, Dr. Cole, for your intervention. I'm checking if Mr. Thomas, I might pronounce this wrongly, would like to share his intervention. Otherwise, we can proceed with another question. Sinatra, I'm checking if there is any signal from our participants, or there is none so far. Okay, cool. I can see the raise hand function. Over to you, Mr. Thomas.
Yeah, thank you very much, and thank you for the excellent presentations. As I mentioned in the chat box, I think the government of Malaysia really needs to be commended for its inclusion of refugees, but also of undocumented migrants in the vaccination program. And I think this is absolutely essential to ensure that everybody can be safe. I think what is still required is a official statement at the highest level that there will be a moratorium for probably a year or two, I would think, on not arresting or detaining persons who come forward for vaccinations in order to have the appropriate confidence with these populations, particularly because we have seen at the beginning of the crisis a statement made that individuals would not be detained in the EMCOs, for example, and unfortunately a couple of weeks later there were various raids. So I think we have to learn from that and really add that element in order to make sure that the vaccination program can be fully successful. Thank you.
Yep, wonderful. Thanks, Mr. Thomas. I think we are about to conclude the Q&A session. Quickly, if I can, not to summarize, but just to share the emerging themes that we have discussed. We touched on the vaccinationalism, access to vaccine in lengthy. Maybe Sinatra, can I pass over to you to maybe, I don't know, to wrap up the whole session.
No worries. Thank you so much, Ainun, for handling the Q&A segment. Just before we conclude, may I invite both of our panelists to deliver like 1 minute concluding remarks, just to wrap up some of their thoughts and ideas that they've brought up to the space today. Maybe we'll start with Dr. MacArthur.
Thank you. I'll just start by thanking ISIS and the American Embassy in Kuala Lumpur for hosting this event. I think it's been very interesting. I've learned a lot, both from Dr. SK as well as the people posing the questions. I think this is clearly a tremendous experience that all of us have gone through. I think life-changing for many of it. It's really touched every individual in this world, which is amazing. I was thinking about the healthcare worker, and I was thinking that of my own experiences, which I won't go into right now, but clearly I think a little bit of rest sometimes for people who are putting in long hours is quite important. As we look to the second year of this pandemic, and we see that certain parts of the world it's moving in the right direction, other parts of the world it continues to move in the wrong direction. So what are some of the new strategies? And I think that was really a topic that was discussed at the beginning. I'm not sure we dove into it. I unfortunately want to say, many of the new strategies are the old strategies. A year ago, 14 months ago, when this started, one of the things I often said was, I don't know. I don't know. It's a new virus. I don't know. And a year later, we know an awful lot more. So I think we do know that the community mitigation strategies do work, that wearing a mask does work, that washing your hands does work, that social distancing does work, that staying away from crowds or in ventilated places does work. And so as we move into year number 2, we've got to continue to focus on those simple activities to protect ourselves, our families, our communities. With that said, we have a new tool, and that's exciting. And a lot of today's discussion was about that new tool. How can we implement it in a fair and equitable way? And I think those are important questions, and questions that are being asked at every level, from the community all the way to the highest level of governments and even in the international bodies. And I think it's going to be an exciting year as we move to roll out that new tool. And on behalf of U.S. Centers for Disease Control and Prevention and the regional office, of which Malaysia is a part of, with whom we work, I'll do everything that I can to help the countries in this region effectively implement that new tool, as well as continue with the old tools. So thank you again for your attention and participation today.
Thank you, Dr. MacArthur, for those kind words and instilling hope in us to brave this 2021. Last but not least, Dr. Ko, for your last report.
Thank you, Sinatra. I enjoyed very much what John has said in his closing remarks, and that is true. A lot of the strategies in the second year are the strategies in the first year. There'll also be the strategies in the third year. And perhaps we should caution ourselves in two things, and I'll end on these two notes of caution for everyone, or things for us to remember, not so much caution. The first is to not rely on a magic solution, as in vaccines are helpful, but they must be placed into the entire spectrum of public health measures. There are no magic solutions for a complex problem like a pandemic, and we need very patient, very unglamorous behind the scenes work in order to make the pandemic work in our favor, so to speak. So that's one thing. Let's be cautious about, magic solutions. And anybody who promises magic solutions, usually politicians. So let me set that aside. And the second note is to say that this is a human problem. And there's a human face to it that we often forget. We forget that there have been 120 million cases, all human beings, about 2 million deaths, all human beings, and then the people around them are also human beings. As the pandemic goes by, it might lose its human face. And I think as policymakers, decision makers, and those listening in, it is important for us to continue humanizing the pandemic as much as we can and not let us ourselves be numbed by it. Thank you, Sinatra. Thank you, ISIS, and thank you, the US Embassy in Kuala Lumpur. Over to you.
Not at all. Thank you so much, Dr. Kaur, and also Dr. MacArthur, for taking some of your busy time in your schedule to speak to us this morning. So I hope everyone here in the audience have learned a thing or two from our panels. I hope we've delivered some of the questions that you had in mind before you attended this webinar. Thank you so much again for joining us this morning. I hope we've earned the privilege of your time and hope to see you in future webinars. Goodbye.